here at Duke, and he joined in 2014 after serving as a medical instructor in the quantitative sciences unit at Stanford. He received his PhD in biostatistics and genomic and computational biology in 2011 from Berkeley. Is that one degree? Just one?
Yeah,
Okay.
yeah.
Sounds like more than one PhD.
Yeah.
He's the recipient of a K Award through the NIDDK on understanding and prediction of cardiac events using real-time EHR data. We actually are also excited to welcome our second speaker for the day, Pamela Barth. Pamela joined Duke in 2014 as a member of DTRI's Applied Informatics Group and now works as a data warehouse developer in the DHTS Analytics Center for Excellence. So please join me in welcoming Benjamin and Pamela.
Thanks. Good. Well, is this on? Okay, well, I'll assume it's on. Well, thank you everybody for being here today. We're really excited to be able to give this talk. So we're going to talk today about using electronic health records for doing clinical research. And when we were thinking about what we want to talk about today, the primary motivation started to stem from a lot of the work that Pam and I and many others, a lot of people here in this room, have been doing with the SETI project. So I think a lot of you are fairly aware of it, but for those who aren't, this was a very multifactorial study using electronic health records to both do some risk prediction, to assess a community intervention, to do some community health assessment. But in my brief interactions with Rob regarding it, one of the big impressions I got from him was that this was also really a proof of concept, particularly a proof of concept around how can we use electronic health records for clinical research. So while we're not going to talk at all about specific findings from SETI. Those results are still being processed through. Perhaps we can give a talk on that in the near future. But what we did want to talk about was take a little bit of a step back and think about some lessons learned along the way about using EHR data. And because, as I think a lot of you are aware here, EHRs have become a really important resource for clinical research, and I think they're really going to stay that way for the near and probably long-term future. So I don't think I need to motivate why we want to use. I don't want to get rid of this. Okay. I don't think I really need to motivate too much why we want to use EHR data, but just to do so a little bit, the primary motivation, I think, for a lot of people, definitely for me as a biostatistician, is the simple fact that EHR data are readily available. If you work at an academic medical center, you have essentially free access to a whole host of data, and in the world of funding shortfalls, that is a really great thing to have access to. It just gives a lot of flexibility to do a lot of both interesting clinical work and methodological work. Obviously, there's advantages to the data themselves. The primary one being is that EHRs are the quintessential medical big data. If you're dealing with Duke EHR, depending on the time period that you're looking, you may have information on hundreds of thousands of patients. You're going to have information collected over a variety of fields. These would be your traditional clinical fields, such as labs and medications and diagnoses, but also more esoteric fields such as radiologic images, streaming data from the ICU, which add a lot of interesting things that can be done. The other interesting distinction is that unlike, say, a registry, which I think a lot of people here have familiarity with, is that you have the flexibility to study just about any clinical outcome. On any given day, I may be working on a study that looks at, say, diabetes, or looks at heart failure, or looks at transplantation. These are all done within the same data source because we have information around that. We're not limited to one single outcome as you would be in the context of a registry. And the thing that's actually probably most intriguing to me, and I think is worthy of actually a lot more research and thought going forward, is the fact that EHRs constitute a truly representative population. And this is really in contrast to, say, a clinical trial, where once you start considering the inclusion and exclusion criteria, it could be very challenging to think about to whom those results directly generalize. And while it's a big open question within this field, how well can we generalize a finding at Duke to, say, a place like UNC or Stanford or another country? At the very least, we know that if we develop a risk prediction model using Duke data, that model is going to be very relevant to Duke patients. If we learn something about diabetes care with Duke patients, we know that there's a true patient population to whom those results can be adequately generalized. And to me, that's a very important and powerful statement to make. As such, there's a whole range of things and studies we can do with EHRs, and they really constitute the gamut of clinical research. So this is actually a snapshot of some of the different projects that I'm involved with here, and they cover really the spectrum of clinical research. A lot of my work within the CPM group is around risk prediction. EHRs are particularly useful for looking at near-term prediction, but also looking at longer-term risk. There's a lot of work going on around population health. There's a project going on in the hospital looking at health service utilization. A big component of the SETI project is understanding the experience of incident diabetics in Durham County. Again, directly from the EHR. There's a lot of great work that's being looked at now in terms of comparative effectiveness research. This can be done somewhat retrospectively, which is, again, you can think of SETI as a retrospective analysis of an intervention where the data came from out of the EHR. And then there's a lot of interesting work that's being done looking forward in terms of prospective studies, point of care randomization studies, and other comparative effectiveness work. And then finally, you have your kind of hallmark of clinical research, your association studies. People often refer to these now as phenome-wide association studies, and then some of your more esoteric data mining exercises. But really, you can touch about any clinical problem when dealing with these data. So that being said, there are caveats. We may not want to use, and why we may not want to use EHR data, and what the caveats really boil down to is that the data are not collected for research purposes. And this is actually the point that a lot of the talk is going to deal with today, is what are those issues and how can we maybe resolve or think about them. But for the most part, the data exist in disparate places. Patients have different pieces of information, and EHR are your quintessential observational data. So for all of the work that you've seen around and the challenge with observational data, in many ways, they're multiplied with EHR. All those same challenges exist, and then even some more so. So with that in mind, Pam is going to talk a little bit about the structure of electronic health records. I'll come back and talk about how we deal with the data, and then we'll finish with some concluding thoughts. Here. Do you want the forward? Sure. Yep.
So hi, I'm Pam Barth. As Emily said, I spent 2 years in DTRI's Applied Informatics under Shelley Rusinkovich, and now I work at DHTS on the Patient Outcomes Research Team, so I play with EHR data all day long. It's very fun, very interesting. So when Ben asked me to join him in his talk, we thought, okay, what value add, what is useful for you guys to know? And we thought, I know that there have been other conversations and other discussions about EHR data, and it sort of is this monolithic, mysterious collection of information. And we thought, okay, well, let's maybe break it down, step back a step, and break it down and look at the different ways how the data flows in the different sections. So that's what I'm going to talk about. So first of all, what's an EHR system? Its primary purpose is to support healthcare. It's to support patient-facing folks. As Ben mentioned, this is not for research use. It is at the point of care, putting information in or retrieving prior information so that you can treat the patient or so that you can handle something that applies directly to patient care. That's the primary purpose. So this, by the way, is not MeisterCare, just in case any of you are looking. It's also not PHI, just in case any of you are wondering. So that's the focus. But when we are looking at something that is created where the application, the front end, is for a different purpose, for immediate retrieval, we're looking at an underlying data structure that is optimized just for one thing, and that is immediate focused patient care. It is not querying from a bunch of different perspectives, looking for diseases or looking for procedures. It is very, very specific. So how do we get around that? Before I move on, I want to say, for those of you who don't know, I think probably mostly do, that MaestroCare is Duke's version of Epic's off-the-shelf application focus. So Intermountain Health or Harvard or whoever else uses Epic, they'll have their own version and they'll call it whatever they call it. So everybody's is a little bit different. It's all been made specific to the health system. So Maestro is our specific version. It's actually an acronym. I have no idea what it stands for. So we have this patient-focused stuff, but what Epic also ships is their version of a data warehouse so that we can use the data, we can pull the data out, we can look at it from a variety of perspectives, whatever we want to see in it. Do we want to look at billing? Do we want to look at clinical billing, patient billing? Do we want to look at surgical information? Do we want to look at radiology? What are some of the subject areas that we're interested in? It contains all of that. But the structure is a little funkier. So this is just the structure, just the warehouse structure for registering an inpatient. That's it. It's nothing else. It's not meds, it's not labs, it's not anything else. That's the structure. So you look at that, and to me it looks like dandelions. So if you think about the data warehouse, it's like a series of dandelion puffs that are sort of vaguely connected to each other. But to use that, that's not really that user-friendly. And that's not, does everybody have to use that? That's a lot to know and it's a lot to learn. So I'm going to hit another slide first, but what we're going to move into is, okay, how do we get this out so that it's easy retrieval for you guys, and then you can move on, figure out a retrieval way that's useful for you, that gives you the data and the structure that you need, so you can move on and do what you're interested in without having to know the dandelion puffs. But first, I want to mention, just to reiterate, I know you all know, whenever you have something that someone touches, if a person touches or if there are decisions involved in that, there is the opportunity for a glitch. You're opening up a risk factor. So just to remind you, every time I say people or decisions, those decisions that are being made when we're copying the data over, I think I missed this part, when we copy the data over from the clinical side nightly into the data warehouse, there are decisions that are made when that happens. Epic's made most of them, Duke makes some of them. They may not be decisions that you would necessarily make. They may be decisions that would affect what you do with the data. So keep that in mind. It's not bad, not trying to scare you. Just know that it's out there. You may not have visibility to what those decisions are. Epic ships out documentation that isn't always really correct. Duke doesn't have a ton of documentation on this. So know that even if they're decisions that you think are wonderful, you may not know what they are. So keep that in mind. So how do we get data out so you guys can use it? So we all can use it, actually. There are three primary methods of pulling it. One is where end users can pull it and use it themselves. One is where you get folks to help, where you find an informaticist. And one is a hybrid model. And we're going to talk about all of these. The first one is Deduce. I know a lot of you are very familiar with Deduce. This is a picture of the front end. It is an end user query tool based on, its primary driver is the encounter. So any patient touch. And it has a lot of strengths. There are a lot of strengths to Deduce. It was built as an end user research tool. It crosses the Epic line very, very, very well. That to me is a really important thing because that's a hard line to cross. Legacy and Epic information, it's great at that. Its strength for the broader community who maybe are nerdy in different ways than I, its strength is data exploration. So if you want to explore your data and look at it and find it and see what happens across a variety of clinical subject areas, Deduce is a very good tool for that. Great for creating cohorts. It is not great because it is not great for publication. And I checked this out I made sure that this was okay to say with the director whose team supports this, and she's the one who said it before me. And I'll tell you why. Because you're doing the querying and you're using this end user query tool, and every possible permutation of how you could do that has not been vetted to the nth degree. So, because that's impossible to do. So there are a lot of decisions that were made to gather the data, to morph, to merge all the legacy and the clinical, the Epic stuff together. And then the front end itself is very tricky. If you query something in one way and then you query it a little bit differently the next day, it's not necessarily going to turn out to be the same stuff. You could get different results. DHTS has training. DHTS has online and in-person training and office hours. Docker has training. There are a lot of ways to use this that are helpful for what you need, but it's not necessarily not ideal for publication. So that's what you can do on your own without any interaction. What you can do for people, what you can do if you think, I don't want to do the dandelion puffs, the whole thing about Deduce scared me, whatever, somebody help me out. There are a couple different ways to get information also out of the EHR. One of them is data extracts, very good for targeted, focused data sets. You have a clinical subject area, a couple of subject areas, and you want to suck that data out and do your own analysis, or you want somebody to create an analytical data set. DHTS, place to go for that. They'll drop the data somewhere for you, you pick it out, you do what you want to with. So it's not ideal for a broad-ranging spectrum or for something that you want to query in a variety of different ways, but it is very good for something very laser-focused. If you want to query, if you have a cohort or you want to create a cohort and you want to have a lot of contextual information, then you create a data mart. An example of that is the SETI data mart, which is refreshed annually. Other examples, anesthesia data mart, breast cancer data mart, Capture 360, which is a readmission risk model that uses geographic information and patient information and a variety of other information. That's refreshed nightly. There are a lot of different data marts that are out there, and a data mart is kind of like a registry. And I know a lot of you are very familiar with registries. They can be cohort-based, they can be disease-based, they can have as many or as few subject areas as you want. But that's one of your options. Because when you build a data mart, you're building infrastructure, like building a city. You're putting down roads, you're setting up power stations, you're putting in water lines. That's not very movable. It's not flexible. So not good for a laser focus. Then the last thing that is generally more used for operations, but can also be used for research, is something that DHTS is moving towards, and that's the Business Objects End User Reporting tool. You can also, I think, suck data out of there and send it to a database. This is a hybrid approach. DHTS sets up the structure. It lays on top of the data warehouse, so it's a nightly refresh. This is real-time data. You don't have to do anything. You don't have to call anybody. You don't have to do anything. The next day you come in, it's refreshed from the last night. But you do the reporting on top of that. You don't have to know the structure. You don't have to know the dandelion puffs. All you have to know is some business language, some common business language that, or clinical language that DHTS puts in place. And so even if you have different structures covering different variety of cohorts, the language that you see is always going to be the same. But that structure, setting up the structure, has to be done on your behalf. So that's the hybrid approach. So again, every time I've said people or decisions or anything that you think implies somebody touching something, you're going to hit a blind spot. Just remember, you may not know the decisions that went into that. That would be something to ask about. You may not have the documentation. That might be something to ask about. Just something, don't be scared, but people touch things. So the last part that I want to throw in is we've talked about the EHR and getting data in. We've talked about getting data out. To go full circle, once we've put data in, we've sucked it out, we've done some things with it to inform healthcare on the front end again, what we do, we can push stuff back into MaestroCare. We do this all the time. The application analysts push small things, things that with little ripples that don't touch a lot of other things. They push those Tuesdays and Thursdays. Bigger things that have larger ripples, they'll push monthly so they can watch and monitor. Best practice alerts, predictive analytics, dashboards, clinical trial recruitment. Hey, guess what? Ding, you get a page. Somebody just walked in who fits your trial criteria. All of these things go feedback into MaestroCare. All of them come from that full circle, in, out, doing something, and then pushing back in. So I hope that this has given you an idea of some of the components, if you weren't already familiar with them, some of the components that go into the EHR, and hopefully demystifies a little bit. And that's it. Now I'm going to turn it back over to Ben, who's going to talk about research.
Great. Thanks, Pam. So now that so once you have the data and then the data have been pulled, they've been turned into either a data mart or data extract. The question then becomes, now, how do we work with them? So before jumping into the issues of actually working with the data, one thing that I think that I hope has become a little bit kind of clear from the beginning is that when you're working with the EHR data, the studies by nature are fairly complex and really require a research team. And this is actually one of the reasons why I love working in this area, is because of the research teams that begin to form. So I hope that Pam has convinced you about the importance of having an informaticist on the team. I'll try to convince you that a biostatistician is needed, and I'm sure that you can convince yourselves that a clinician is needed. But what is really great about these teams is that, and this is obviously a gross simplification, but all these people really bring both a unique skill set to the table, but at the same time, some overlapping areas of expertise too. And in my experience in working on these projects, this is what has really elevated the process and the projects, is having two people, for example, dealing with someone like Pam, who we're both thinking about around issues of data manipulation, but we're just fundamentally thinking about it differently based on our background and based on our trainings, coming to a larger and greater place. So that being said, what are some of the issues that come about in dealing with these data? Thinking about this, there's 4 ways that I see that EHR data differ from traditional clinical data. And then I'm going to touch on all 4 of these in some ways that we can try and resolve these issues. So the first is that we don't have everything we want. The second is that the outcomes are not well defined. This leads to the need for what's called phenotyping data. The data are irregularly and potentially densely observed, which creates some analytic challenges. And then finally, the data are not observed randomly, something that I've taken to calling informed presence. So this first issue, most EHRs are incomplete. And while we have a lot of information on patients, there's definitely going to be a lot of missing information that we're going to want in our research studies. So one of the issues, for example, that came up in the study project is that a lot of the patients that we were interested in, who maybe got their hospital care at Duke, were getting their primary care at the Lincoln Health clinics. This is a fundamentally different system. They weren't going to the Duke clinics. If we wanted to see and get an understanding of their diabetes care, we needed to link in that information. So that's been a very challenging undertaking, but a very important part of the process. How do we bring in that information? We can obviously extend that to things like how can we think about bringing in information from places like UNC or Wake Medicine. These are what efforts like PCORNet are aiming to do, to try and bring in information from across different encounters. Another piece of missing information is that is we don't see individuals when they're healthy. This is probably the fundamental bias that underlies all EHR analyses, and something I'll spend a lot more time talking about a little bit later. And at the end of the day, we just may not contain some of the data that we want, so we need to find other ways to link in other sources of information. Fortunately, it's actually pretty not straightforward, but it's very possible to link in these informations either within the EHR itself or after the fact once we have our data mart. So I mentioned PCORNet. You can also efforts to link in information from CMS claims. I'll talk about in a little bit the importance of looking at linking in information on mortality, whether that's from the NDI or the SSDI. There's a lot of interesting work right now about how to incorporate genetic data. This may be embedding the genetic data directly into the EHR if someone's being genotyped locally, or if someone's comes with third-party information from, say, a 23andMe, how do you bring that information into your analysis and link that in? Pam mentioned the Capture 360 database. This has been a really unique resource. So there's a lot of interest now in bringing in information about neighborhoods, the built environment, geocode information. And so a lot of this information comes from the American Community Surveys. And this has been integrated using census tract level information into the Capture 360 database, and other resources allow for these really fine and more granular assessments. And then finally, there's a lot of really neat work, I'm working with some folks over in the hospital looking at how do we bring in personal tracking data. This may be through things like Fitbits or through sensors. We're looking at a pilot project for essentially giving patients on the ward a medical grade Fitbit, essentially, so you can do 24-hour monitoring of heart rate and blood pressure and pulse and whatnot. Again, this is all information that needs to be linked in somehow to the other available data. The second issue that arises is how do we actually define the data elements that we're looking at? So one of the really easy and kind of taken for granted things about doing a clinical trial is that all of the events that you're looking at are probably well defined and even more so well adjudicated. When someone has a heart attack, it's been defined by the clinician that that was an AMI. Somebody has diabetes, there was an extensive review to make sure they're actually a diabetic. When you're dealing with the EHR data, there's no field that actually says heart attack. There's no field that actually says diabetes. You may find sometimes people work with what are called problem lists, but for the most part, there isn't a clear definition. So one of the biggest components of the SETI project, and I think a lot of you have been roped into this, or your fellows have been roped into this, is going through this very extensive phenotyping process, and to go about trying to define what is a diabetic, what is an AMI. So this is one of the early papers that came out of SETI, where the thought was, well, let's think about how we can define a diabetic. So we can define a diabetic based on ICD-9 codes, based on what medications, or based on their lab results. And among 25,000 people who had met one of those three criteria, about 40% had both an ICD-9 code, an abnormal lab, and a medication for diabetes, which means that a plurality of people have only one or two of these in their chart. It may be that someone has a diagnosis for diabetes, is taking medication, and over the time frame in which you're looking, their labs have been perfectly normal. So they wouldn't come up through A1C. It may be that somebody is pre-diabetic or has diabetes that hasn't been actually diagnosed yet or been captured yet, so they don't have any meds or an ICD-9, but they just have an out-of-range A1C. So this actually leads to the very important question, well, what actually is a diabetic? So there is a very extensive undertaking to actually compare 7 different definitions for diabetes. I believe about 100 or so charts were reviewed by multiple reviewers to create a gold standard for what a diabetic truly is, and then to compare, well, which definition performed best. Now, as always, best is relative. What is best? What is the right definition? So this is a zoom in of an ROC chart, and so familiar looking at these, this is sensitivity on the y-axis, specificity on the x-axis, and what we see is that if you want a definition that captures the most amount of people, the most sensitive, this orange definition works best. This is what we call the DDC4 definition. It's essentially a kitchen sink definition. If you have a lab, if you have an abnormal lab, you have a medication, you have an ICD-9, we're going to call you a diabetic. All comers are accepted. However, not surprisingly, it's also the one that has the lowest specificity, meaning it had the most false positives. Conversely, the definition that had the greatest specificity, captured the most true diabetics, is one based solely on labs, just looking at an out-of-range A1C. Not surprisingly, this missed a lot of people, presumably those people whose labs are under control. This raises the specter of, okay, that there's choices to be made. It doesn't answer the question of which one is actually best. And this is actually a project now that my group that we're working on is we're actually going to explore what are the different implications of choosing a definition that has high sensitivity or high specificity, and what does that mean for the analyses. There's been a lot of work in terms of going through different phenotype definitions. Obviously, we spent a lot of time on the cardiovascular definitions. But to me, one of the most interesting definitions has been looking at this death definition. This has been led by Charlotte Nelson, trying to figure out how well do we capture death within the EHR. And when I was first exposed to this question, it kind of fascinated me, but it makes a lot of sense. EHRs are a very poor source for finding out who dies. Because unless a person dies in the hospital, you're not going to find out about it. If someone dies at home and never touches the healthcare system at the time of their death, the EHR system is not going to know about it. So led by Charlotte, we're linking in information with the NDI and SSDI to get a true gold standard. And then we're actually doing some comparative work with the Duke Data Bank to see how well can we actually come up with a phenotype for death. The next issue that arises in terms of dealing with these data, and this is actually more of a challenge than really a caveat or a concern, is this question of multiple measurements per person. And when I started working with the EHR data about 4 or 5 years ago, this was actually the component that intrigued me the most, was this opportunity to observe patients' evolving health status. And unlike a trial or a large epidemiologic study where you're viewing patients every 6 months or once a year, when you're dealing with EHR data, you really have the opportunity to observe dense information on patients. This may be over a course of a series of health encounters. This may be over a 72-hour hospital stay where you have updated labs or medications or vitals on a person every 4 to 6 hours. But you have this opportunity to really observe what's going on with the patient. But this also raises a lot of challenge of essentially how do we deal with this information. Traditional statistical techniques are not well suited for dealing with data that are regularly spaced, are very dense. Methods have been developed really with the clinical trial context in mind, where every quarter there's 1 visit per person. It's not clear how do you handle a patient that has 5 visits over a 10-day period. This has led to a lot of different methods and how to deal with the data. And then, of course, as always, there's that underlying issue of how do you know what you're not seeing in the data. But what I want to convince you of is that these data present a lot of really fascinating analytical opportunities. So this is data that comes out of actually a dialysis EHR system, where we are interested in looking at how labs change for patients before the incident of an event. So this was a sample of patients in the red line, people that have an AMI, in the blue line, people that don't, randomly sampled controls. And what we see is that about 2 to 3 weeks before this incident AMI, the white blood cell counts begin to spike. Now, this is not a causal finding. This is all minimally adjusted. This is actually done within a risk prediction context. But it's something that we were able to do because we had this dense, regular monitoring of the patients as they were going through the dialysis care. This is something that this is not an analysis we'd be able to do if we were only viewing patients once a year and getting 1 lab value at a time. We can also look at information over much denser periods of time. So this is, again, looking at the dialysis patients. These are blood pressure curves on patients over a 3-hour period. Again, these curves these measurements are taken about every 5 minutes. Patients may have data about 12 to 20 data points over the 3-hour session. And what we see is that every individual has a slightly different blood pressure curve. This should raise a lot of interesting questions about, well, what are the implications of one's blood pressure pattern? How does this relate to risk? How can we maybe modify if we observe an ideal blood pressure pattern? But what it also raises, well, how do we actually take data and perform these analyses? So for the most part, the field has actually focused on the left-hand side of the column of summarizing data, looking at things if you have, for example, blood pressure data over a 3-hour period, looking at mean or median values, looking at extreme values, variability of measurements. Joe Lucas here has actually done some really fascinating work looking at the number of measurements, showing that just simply the number of glucose tests that a diabetic receives over a period of time is predictive of bad outcomes. And for the most part, these summaries actually do quite well. Something we're exploring a little bit more on what are the limitations of summary measures, but they seem fairly robust if you're just thinking in terms of a risk prediction standpoint. But if you want to get to a point of some insight and understanding, that's where some more advanced modeling really is required. So, and there's been a lot of really great work over the last few years in the statistics community trying to develop models that are appropriate for these data. So those graphs were actually created using regression splines. It might be familiar to most people here. There's a lot of really neat work going on right now in the field of what's called functional data analysis. This is presuming that each person has an underlying curve and then trying to estimate that curve on a person-by-person level and looking at variability off of that. And then there's also been some really great work around what are called joint models, essentially fitting a regression spline on the longitudinal data and then incorporating that into, say, a survival model to try and look at both processes at the same time. So the point around it is that there are actually techniques out there to analyze these data, but it's not going to be your typical run-of-the-mill analysis that you can just plug into SAS or R and run with it. To really get these types of insights, you need to be a little bit more thoughtful and creative about how you actually set up the data and analyze the data. So the final point that I just wanted to touch on is this has been the topic that I actually find the most interesting and I've been spending probably the most amount of time on lately, is this question of informed presence and what are some of the underlying biases within EHR data that relate to the fact that we're seeing patients only when they're sick. So the reason why I like the term informed presence is that while it's essentially a missing data problem, there's information that we don't observe, the emphasis to me is really on there's a problem with the data we are observing. Namely that the data that we're observing are when patients are sick. We're not observing when they're in a particular state, and how do we deal with that? The other problem is that we're only seeing information that's been deemed to be important. So if we only see data, if we have a lab test on a patient, that is not necessarily a randomly generated lab test. That's a lab test because a doctor has made the determination that a lab value is needed. That's exactly why using just simply the number of labs performed without regard to what those actual values are is actually pretty predictive. The other issue, and this becomes more salient once we start getting to the world of merging across different EHR systems, is that different environments have different policies. So if we were doing a study where we were combining Duke data and, say, UNC data, any systematic differences in terms of how those patients are treated may actually lead to some biases that may infiltrate the study if we weren't appropriately taking account of them. So how does this informed presence actually come about? So this is a small sample of some of the study patients. It was a little pilot initiative. We're expanding this now over a larger sample of the patients. But what we looked at was about 50 patients and just looking at their mean systolic blood pressure over a series of different encounters. So we can think about this home visit here as this was a random encounter with a clinical health worker. There was no reason that the patients were visited. They weren't particularly sick. They just had a scheduled visit that day and their blood pressure was taken. And now we have 3 different places where we encountered EHR data in the inpatient setting, the ED setting, and the clinic setting. And what we see is that the average lab values are higher across the board. The only statistically significant difference is between the ED and home visits. Like I said, we're now trying to do a more fine pool out of the EHR data to make sure we get the cleanest data possible. And the real question that we're interested in is one, is this a problem that's across the EHR? Is all EHR data going to be perhaps more extreme than a random encounter? Or maybe we can identify that a clinic visit maybe is a little bit safer, but the ED visit, where someone's in their most acute state of care, is maybe less safe data to use. A second problem that arises is that, and this is something that came out of one of the analytic projects that came out of SETI, is the observation that the number of encounters can actually serve as a confounder for any basic association analyses. So for those who are familiar in terms of looking at causal diagrams, let's say we're interested in seeing how weight loss relates to risk of depression. This is the association we're most interested in. And Clearly, people that have and I'll explain in a moment why I chose these two examples, but clearly people who have a history of weight loss may have an increased number of visits. People with depression may have an increased number of visits. Going back to thinking about the phenotyping problem, what we notice is that just because somebody has a diagnosis, that's not going to correlate with us actually observing that diagnosis. Because of issues of sensitivity and specificity, there's going to be some error there. So while the analysis we want to do is here, the analysis that we have to do is on the observed data. So for those who are familiar looking at causal diagrams, the number of visits is a confounder of our observed relationship. Now, for the savviest people in the room, and I'm guessing, and I think some people may have picked up on it, is that this becomes actually even more complicated. Not only is number of visits a confounder, it's also what is called in the causal inference literature a collider, in that it's a descendant of the observation we actually care about. So this, so we looked at this to try and see, well, how does this bias create itself, and is there anything we can actually do about it? So I'm not going to talk about the issue about solving the collider issue, but just even looking at the confounder issue. So the reason why I chose depression and weight loss is that these are known to have very poor sensitivity in terms of capturing. The people that we were able to diagnose with depression and weight loss had many more encounters than those that did not. So we now see a clear potential for there to be confounding. And when we just do, this is just a basic run-of-the-mill association analysis, if we don't adjust for number of encounters, we see a very large odds ratio of about 4. This gets cut in basically half just simply for controlling for the number of encounters. Again, the inference is the same, but the implication obviously may be a little bit different. We are curious about how this relates to say, comorbidities. If we just adjust for, say, the Charlson Comorbidity Index, do we see the same effect? And we do see a similar attenuation, but to me what's actually most interesting is that when you control for both encounters and comorbidities, there's actually not much of a difference in the overall attenuation, suggesting that actually this number of encounters is able to sop up a lot of what's going on in terms of that overestimation. Again, a very simple example, a very simple solution, but a showing of how this can infiltrate most analyses. A much more complicated case, so this is actually a project that I'm working on now with Lane Thomas, is how are more complicated forms of confounding when you really care not about association but true causal inference. So if we care, for example, about how a biomarker, say A1C, relates to risk of AMI, this may be the relationship that we care about. But if our biomarker is affecting our probability of actually observing that biomarker, so let's say a patient comes into the hospital because their A1C is particularly out of whack, they're feeling particularly unhealthy that day, and that's the only time we actually observe it, that's going to severely bias any of our analyses. There could be other factors that are both driving driving one's biomarker and also driving why we actually observe that biomarker. This is actually a potentially very insidious form of confounding that we're starting to look at how solutions like IPTW can resolve it, but it's also very likely that for the most part, that there won't actually be a real tenable solution without making some very strict assumptions about this process. But again, these are things to be considering once you start moving away from just an association, start thinking about what's some of the causal impact of say, a biomarker and an outcome. So with that, I just wanted we just wanted to wrap up and give some concluding thoughts. And I didn't want to end on kind of this note of, is it all bad? Because I wouldn't be doing this if I thought it was bad. I'd probably, I guess, move back to the CT stats group or something like that, where the real glory is. But I don't think it's bad. I think there's a lot of opportunities, and for one, we can do a lot more studies. More importantly, we can do a lot cheaper studies. Like I said, these data are readily available. They're not collected for research, but they're there for researchers to use. And with appropriate understanding of what you're using the data for, there's a lot of great work we can do. We can do a lot faster studies. Once even by using a query tool like Deduce, you can very quickly create a cohort, test a hypothesis, see if there's something there, get involved with your local informaticists to get a much more well-defined data set and turn something out. These are not the type of studies that you can do if you needed to actually recruit a bunch of patients and run a full trial. And from an IRB perspective, these are usually coded as actually retrospective studies, which also make them a lot easier too. And then for me also, there are perhaps more representative studies. And to me, that's really the key, is that when we start thinking about public health and population health, there's a lot more opportunity, even with all these underlying biases and challenges, of analyzing a group of people that are real people. These are people that, these are patients, you're looking at patients that you're dealing with in the clinic, and any findings are potentially relevant to the care that you're hopefully giving them. That all being said, there is extra care needed. This wouldn't be a statistics talk if it didn't end on a slightly dour note. So we need to be mindful from where the data come, that there's not always one way to turn raw data into analytic data, and as much as possible be aware of that process. I really believe that which data we cut is actually more important than how you go about analyzing it. If you can spend 80% of your time just creating your data set, that's going to do a lot better, and then as opposed to trying to spend 80% of your time analyzing the data set, you'll be a lot more efficient with your time. And then where I think a lot of the fun comes in is that new analytic techniques will often be useful, and then we can also pull in old analytic techniques too and apply them to new and interesting problems. And I think with that, I guess we have a little bit of time still for questions. Thank you. Harry?
So you brought up the fact about where the data are from, being able to understand that as being an important part of being able to do analyses. And I know from having worked, when I first got here, I worked with Duke data, and then over the years I've worked with clinical trials data. And I think one of the things I love about clinical trials data is I know where the data came from. I can see the raw data. I can see how I got from raw data all the way up to my analysis data set. And I have a description of how it got from raw data to an analysis data set. And it seems that now we've moved more into an era where the statisticians don't have that. We don't have documentation on what's going on behind the scenes. It's a black box, what we're getting. And I realize we have informaticists to help out, but it feels like that as a statistician, we no longer have the ability to be part of the discussion of like raw. How is somebody going into that raw data and making the decisions about what they're giving to us? And I would hate that.
So here's what I would say. And did everybody hear the question?
No.
Okay, the question was, it seems like there are a lot of decisions that are being made and it's a black box, which I think is a valid point. That's a valid point. So when you talk to,
Yeah.
yeah, sit down.
Yeah.
So when you talk to your informaticist, what you do is you say, okay, this is where the bonus is of having someone, not just doing it yourself and going to do-dos, but you talk to your informaticist and you develop a relationship and you both sit down, however many times it takes, and you say, all right, let's talk about how this goes in. Let's talk about what decisions we're making. Let's talk about, okay, you ran into this funky thing, call me up. Let's figure out how to deal with this. You get, not only is there documentation, usually after the fact, after you figure out what you've done, but you get into the part where you're actually working with the informaticist about how the decisions are being made. So I can't answer the black box question about how the data moves nightly, which is mostly Epic written, from the EHR into the data warehouse. But once it's in the data warehouse, find an informaticist and sit down and spend time. And that's where your 80% is going to come from. And that's where you get your visibility. And that's how you know what you're getting.
And just even off that, what I would say is that the anxiety that I imagine a lot of clinicians feel when they have to hand over the analysis to the statistician and say, trusting that the analysis is done properly, I feel like that there's a similar type of trust when you're working with an informaticist too, right? But they become an integral part of the analytic team. And I think in many ways, that the way, and you know this better than I, the degree to which statisticians have had to push for themselves to be part of that integral analytic team. I think you're seeing that a lot more now within the informatics community, that recognition that as statisticians, we can't do it all. And I often, when I start talking about a research project, I often say that there's this, the research project is a continuum. There's how do we get the data, what do we do with the data, and then what do we do with the data after the fact? And I usually say, I just do that really tiny middle part of what do we do with the data, but there's a whole world of people who are responsible and much more knowledgeable than I about how do we actually get the data to an analytic format, and how do we turn that data into a useful tool. I went into this thinking, I'm going to get Clarity trained, I'm going to learn about Epic, and as soon as I started seeing that, I realized that it's such a big world that we need those specialists. And they need to be part of that clinical team. Eric.
For one of the other left out groups, if the statisticians feel that they're sort of out of the loop, I might argue that the clinician researchers might also want to have their voices heard here. Because in fact, some of the questions you're raising with regards to what you're seeing in the data, in fact, reflect things that we might know clinically. Blood pressures generally are higher in EDs because people come in with pain. So that's one we probably could have gotten and worried about and brought to your attention. You guys got it as well, but there are other examples where, in fact, clinical insight is occasionally helpful.
No, and I think that goes without saying. And like I put up there, I mean, to me, it's a research team. I started on this, thinking, okay, I'll just start working with these data, and very quickly I realized I needed to be embedded within a clinical environment. As Emily mentioned, a lot of this has come out of K work that I've done. The primary mentor on my K is not a statistician, it's a clinician. It's because it's necessary to have that clinical perspective. This isn't work anymore that can be done by yourself. This is work that truly is team science, and to me that becomes really exciting. Michael.
In reference to Karen's comment and Pam's response, I kind of anecdote you're saying talk to your informaticist reminds me like talk to your geneticist about things. New areas are developing, but I think the world is changing. And another parallel to the presidential elections, right? In the past, at least, not a comment on any candidate. In the past, the idea was once the two parties select their people, the one who is able to move into the center and push the other one to one side of the extreme is going to do well. And I feel and I'm saying it very lovingly, the informaticists are doing just that. They're pushing to the big center. Ben is talking about 80%, that they are going to do a lot of the work. And I'm loving it in the sense that it allows me to be a statistician, focus on the things that I've been trained to do, and somebody else is going to take care of the data for me, that's how we train statisticians anyway. Now, I do recognize that many people here in the profession, statisticians, good statisticians working on many projects, the understanding of the data, and what Karen was talking about, was foundational to what they were doing. So there is the tension between the two professions. We'll see how it's going to develop, but I think the reality is such that we will need an informaticist if we want to work with EHR.
Anyway, so just a couple things. Coming recently from VA, I'm a true believer in EHR data for the reasons that you talked about, that it's real data and representative, but you obviously need to know what's going in and what's going out. And because VA's had EHRs a lot longer, their documentation's better, and the decisions, I think too, as it's backed up and what it means to have the data cleaned and the accuracy of a lot of the variables. I mean, I think we just have more information about it. But, and there was an interesting study out of the VA Center here, which you might be interested in, because it was exactly about blood pressures. They had clinical blood pressure, so you came in the clinic, they had like home blood pressures done by, the trained research staff, and they had all the issues of multiple measures to deal with. And the conclusion they came to is actually the clinical blood pressure at a clinic visit is kind of useless, because it didn't correlate with anything else that they got outside of a setting, not even an ED. But it's an interesting paper, and the analysis of all these data were interesting. So I think this is great. I think the biggest barrier, challenge that I found moving from VA type data to other is what you said about trying to get outside that one system. And my understanding of PCORNet is that actually isn't necessarily a solution to it, because my understanding is that there's no unique patient identifier across systems, that each health group puts in their data with their unique thing. And so if somebody went outside, you wouldn't really be able to cross it over. And I just wanted you to clarify because that is, one of the things, you'd like to be able to see even locally what else is going on, not just in a Duke Center.
So I'm not an expert on pCornet, so I'll defer to, I don't know if either Emily or Shelley have more just I'm not an expert on the pCornet itself.
Well, Emily and I are pointing at each other. I'm on someone. So in Adrian and Leslie's absence, I'll just say that it certainly is a consideration with the Cornet, where there are standalone healthcare settings to do that integration. Some networks have been able to perform that, such as Capricorn, others have not. But a power of the Cornet is probably in two areas. One is integrated care delivery settings, such as Kaiser, Intermountain, Geisinger now, and that giving us some power. And also in the Cornet having a lot of different data partners at the table, which can be the continuum of EHR clinical data with claims and reimbursement, which gives us then that perspective of what has been reimbursed for a given patient. So I wouldn't say that there is one solution that will fit everything, but the Cornet being a testing ground for many different ones.
So, one question. The comment is apropos of this. It seems to me that from what I've seen, there are enormous differences even between very similar health systems and the EHR. So we've been doing some work with the Kaiser Group and the HCSRN, and between 4 Kaiser groups, the coding of different entities is totally different. And to get that into one data set, they had to go through huge hoops of I don't know what you call it, but getting them together to make them able to be in the same column, essentially. So I think you can't minimize the difficulties in trying to merge data sets,
Absolutely.
even from fairly similar systems. I mean, they have they have the same health record, and it's all Kaiser, but they're like Kaiser, Northern California, Southern California, they have big problems in merging with it. So, but the question I wanted to ask is, from a clinical standpoint, the bigger issue than all these issues, is probably one you can't answer, but maybe somebody can help, is what data's in there in the first place. And you alluded to that a little bit. But there are areas which are traditionally very, very poorly represented in medical records, whether they be paper medical records or others. So for example, functional status is a classic of this. And as our population's aging and we're looking to do studies that are relevant to the older population, it's all about function. You can't find any good indicators of function in a paper record or an electronic record for the most part. So the question I have is, how do we get that stuff into the electronic medical record?
So some of it is there. So like, for example, we're working on right now for risk of inpatient, for inpatient risk of deterioration. And we do have information on level of consciousness and status, and so some of these more subjective things. But you're absolutely right that a lot of these qualitative assessments are missing. And what's actually fascinating, so a colleague of mine, but
It's just that nobody puts them in there.
no, but also, and even things that
Or
are
even tests them.
so that, but even more so, so a colleague of mine, he looked at the notes. And as Epic systems become more common and things are turning from notes to drop-down menus, what they started finding was that there's less information content in the drop-down menus than there would be in the patient notes. So even though notes are traditionally very difficult to deal with, you have to go through natural language processing and a whole other, you basically have to deal with a whole different team of informaticists to access those data. Once you lose the notes, you lose actually a lot of information that aren't being captured by Epic-style drop-down menus. So it's not only are some things not even being coded, things that used to be put in there are actually being lost. That being said, one thing I've noticed is that the community is actually starting to recognize that in terms of trying to query extra information. So through things like Duke MyChart or analogous systems, sending surveys to patients, to get information on quality of life, to get some of this more subjective information, and then re-embedding that into the EHR. At the most recent informatics conference, there were some really interesting talks about techniques around doing that. So I think actually I think you're right. I think it's a problem that people are recognizing, and I think that there are now solutions that people are starting to think about. How can we use some of these alternative structures that may not be the doctor, but may be other means of bringing information in to the larger chart?
I think it really goes back to what you said. It's what information's deemed important, and a lot of the drop-down menus have been driven by coding and billing, unfortunately, not patient care,
Right.
and certainly not billing. So, and then you lose some of this other data that, we traditionally recorded, but, didn't affect what level visit it was. So, you have to decide it's important. I mean, the good thing is it's, relatively easy to incorporate standardized data from, a functional status, instrument. And you could have various ways of collecting it. The problem with my chart is such a low percentage of patients usually do the patient portal, but if you had kiosks at visits or some other method of putting it in, I mean, it's relatively easy to put it in. The key is, how do we get it in there? We say it's important, and until somebody says it's important, then it's not going to happen.
And I think this is also where the opportunity for prospective studies becomes really fascinating, where if you identify that this is the patient you're dealing with, we want this particular extra information about them, there's nothing that stops you from creating a dashboard that particularly asked the doctor, we're doing a study on heart transplant patients, so we want to capture additional information that isn't typically captured. And I think that's really the next frontier of using these data. Not traditionally, they've been used from a retrospective context, so it's just what you see is what you get. I think people are now starting to think more about how can we manipulate the EHR to collect this information that we know a priori we are going to want. Carrie? Yeah.
And it seems to me this is really a major new frontier that you all are tackling, and it's really admirable, I think, the progress that is being made. I guess the biggest concern that I would have, particularly in terms of trying to answer research questions, is the quality of the data. And do you think this is going to evolve to the point that people will be able to stand behind the quality of the data, given all of the caveats that you've got many different people entering information into the system, many different clinicians, et cetera. There's not a lot of sort of, well, I don't know what sort of internal checks exist to eliminate nonsensical information, but is this going to evolve, do you think, to the point that for answering research questions we'll be able to stand behind the quality of the information?
So I think there's two answers to that. One, I think yes. I think as we begin to understand its role in research, more of those checks are going to occur, and a lot of those checks happen in the data mark creation process. So there's that process of creating an analytic data set. The other kind of more tongue-in-cheek answer I'll give, this is quoting Atul Butte, who's a well-known informaticist, is that I heard him once say, in 50 years we're going to be complaining about the data we collected 49 years from now. With the idea being that data, we're never going to have the perfect data, and I truly believe that. I think once we become comfortable with the data we have, there's something fundamentally wrong. We should always strive for something better, but we have to make do and do as good of a job as we can, all the caveats in mind, to try and use it as good as possible. That being said, there's always a point where you have to make that decision. Has the data crossed a threshold where it's flawed but useful versus flawed but useless? And I think that gray line, comes up in just about every project, and it's a very tough call of when have we reached that point where there's just too many underlying biases that it would be malpractice to publish this paper.
Thank you.